Good morning, everyone. A warm welcome to all distinguished speakers, colleagues, and participants joining us today. I'm Gita Anandam, a third-year Emergency Master's Program student from Universiti Kebangsaan, Malaysia, and your moderator for today's session. It's truly a pleasure to have all of you with us for the second week of the 7th Emergency Medicine Seminar Series 2025 on the topic of marine envenomation and poisoning. I want to take a moment to thank our CME advisor, Associate Professor Dr. Ahmad Khaldun bin Ismail, for his ongoing guidance and support in making this seminar series successful. Before we begin, I would like to express our appreciation to the organization committee for their continuous effort in sustaining this education platform, as well as our collaborators, organizers, Universiti Kebangsaan Malaysia, Universitas Brawijaya, and the University of the Philippines. The co-organizer, Toxinology, Education, Resource and Development, in collaboration with Wellness, Austere Medicine Society, Malaysian Society of Toxicology, Remote Envenomation Consultancy Service, Pusat Racun Negara, Malaysian Society of Toxinology, and Malaysian Biodiversity Information System, and it's sponsored by J.A. Nabila and co-advocator as Wellness Austere Medicine Society, Remote Envenoming Consultancy Service, Malaysian Society on Toxinology, and Pusat Racun Negara. We have an exciting and informative lineup for today. Our first session will be explore sea snakes and other marine innovation. The second talk focus on poison by the sea, covering important clinical management and envenomation. And finally, we will learn about the shellfish-related poisoning, including the paralytic shellfish poisoning syndrome. Each topic will be followed by a questions and answer sessions. So please feel free to submit your question via the chat or during the open discussion later. Now, let's begin our first session of the day. It's my great pleasure to introduce our first speaker, Dr. Yon Teo Chiang Hoon, who will be speaking on the topic sea snakes and the other marine innovation. Dr. Yon, she is an emergency physician and the head of the emergency department of Duchess of Kent, Sandakan, a position she held since 2018. She obtained her medical degree from Universiti Kebangsaan Malaysia in 2008 and her Master of Medicine in Emergency Medicine from University Science Malaysia in 2016. Dr. Yon is also a REX consultant since 2018, and she completed clinical toxinology training in Adelaide, Australia, 2019. With her vast experience in emergency care and toxinology, we are privileged to have her with us today to share her knowledge and real-world experience in managing marine envenomment cases. Please join me in welcoming Dr. Yon Teo Chiang Hoon for her presentation entitled Sea Snakes and Other Marine Envenomation.
Okay, so hi everyone, good morning. Having me in this webinar. Okay, so I will be sharing on marine envenomation. So what we'll be covering today is number one, to know the various types of venomous marine animals. Okay, how they actually cause envenomation, what are the mechanisms, what are the signs and symptoms of all these various marine animal envenomation, and how to manage them one by one. So first of all, it's very important for us to differentiate, okay, the difference between venom and also poison. So venom is actually, it needs to be injected into our body, is via whether it's through stings or bites. But poison, it is you consume it or you inhale it or it's absorbed through the skin. So today we will talk about marine envenomation, which it need to be injected into our body through several mechanisms. is either through the nematocysts, okay, the stinging cells, or bites, or through stings and also spines. Okay, so I will start with the first one, which is the nematocysts. Okay, so marine animals which have this nematocysts is actually under the phylum of Cnidaria. So under the phylum of Cnidaria, there are several family. Okay, and the most worrisome one, okay, is the cubozoan and also the hydrozoan. So under the group of cubozoan, we have Chironex fleckeri, okay, and also we have the carabid. And hydrozoa is the blue bottle jellyfish. Okay, so all these actually we call as Cnidaria. So why Cnidaria has this nematocyst and what is its function? Okay, if you can see this video, okay, let me play. Okay, so once the nematocyst attached to your body, okay, it actually can stimulate, okay, the encapsulated harpoon is embedded inside it, and it will actually inject the venom, okay, once it is stimulated, just like how this video play. Okay, all right. Okay, so even the jellyfish, okay, is already dead, it still can potentially cause envenoming. Okay, so do not handle all this jellyfish, even though it's dead, with bare hands. Okay, there are many types of jellyfish in the Malaysian waters. So the highlighted red one is the one that we are worried of. Okay, so for example, the Mubaka species and the Chirosoides dinchki. Okay, so when we say box jellyfish, or the most harmful jellyfish, we divide into two types, which is the single box jellyfish. Okay, so it's box, so it got 4 angles, so each angle got one single tentacle, and also the multi-tentacle box jellyfish. So the famous one is actually the Chirokia barnense for single tentacled box jellyfish, and also Chironex for the multi-tentacled one. But these are in the Australian waters. So in Malaysia, we have the Murbaka fenneri, okay, single tentacled box jellyfish, and also the multi-tentacled one, we have Chirosoides buitendicki, so Chironex yamaguchi. So for tentacled box jellyfish is multi-tentacled. So when it latch on your body, it will actually cause this typical welt swelling, okay, which is horse latch, okay, and it's very painful, okay, and patient can go into cardiac arrest immediately, okay, will have respiratory arrest, okay, other than having this, and also the whiplash lesion. Single tentacle jellyfish, okay, it can actually cause this Irukandji-like syndrome, which is like the catecholamine storm when the body is having simple mimetic toxidrome like this. Okay, so the patient will actually because tentacle, so the skin lesion is not really that significant. However, patient will have this catecholamine like syndrome when the heart rate will go up, the BP will shoot up, the patient will have excruciating pain later on. It's more to like myotoxicity. Patient has severe back pain, okay, and also it's like it will cause like doom-like symptoms also lah. Okay, and this is hydrozoa or blue bottle jellyfish. Okay, the famous one is Physalia physalis, or we call it blue bottle Portuguese man o' war. Why is it called Portuguese man o' war? Is because of um the s- the look of it. Okay, it's like the sail of the warship. Okay, so actually does not swim, is actually just float on the water, so you are able to visualize it. Okay, and it has this beautiful color, blue in color. So when it stings, when the tentacles attach to your body, it will cause this typical lesion, which is bead-like lesion, is in a linear line, okay, with nodules, red nodules on it, papules on it. Okay, then this next is the fire coral or anemone or hydroids, okay, another types of Cnidaria that can sting. So you have the hard corals and the soft corals. So the hard corals, it can cause mechanical injuries, and the soft one, it can actually also cause skin irritations. So these are the typical lesions, okay? Erythematous nodule papules, okay? It also can cause macular papular lesions, which is it can be itchy. It can also be burning pain in sensation. So this they can cause pruritic dermatitis. It can cause edema. So if you live for long, some will have the complications of having hypertension. So what is the treatment? Okay, first is you just irrigate with seawater or saline. You can also apply corticosteroid and give antihistamine if the patient have itchiness. All right, so when we talk about jellyfish envenomation, okay, once you are stung by jellyfish, okay, the most important thing is you have to get out of the water as soon as possible. Okay, once you have pain, you don't know whether you are bitten or being stung, okay, please come out of the water immediately because you do not know of envenomation will happen. Okay, so you must time to surface out of the water immediately because you might have cardiac arrest. Okay, so if the patient have cardiac arrest, please commence your CPR immediately. Then next is pour vinegar, okay, on the wound, okay, because what we are afraid most, okay, the most venomous one is actually the box jellyfish, which will cause cardiac arrest. So this vinegar actually it will deactivate the unfired nematocysts from firing further so that the venom will not be delivered further into the body. So it is good that we straight away apply, okay, or flood the stung area liberally with vinegar for at least 30 seconds. Okay, so there's some controversial issue whether it will worsen blue bottle jellyfish or not. Okay, but give the type of benefit to the box jellyfish, just apply the vinegar. Okay. Right, next is to remove the tentacles, okay, by scraping it off, okay, and do not apply any pressure on the wound because pressure actually activate the nematocysts to fire more, okay. Next is to apply hot water immersion. So hot water immersion, it can help to modulate the pain. Okay, so it's a good painkiller. So how do you do the hot water immersion? Is by by soaking the area. Okay, um, in hot water, 42 to 45 degrees Celsius for about 30 to 90 minutes. Okay, so or if you do not have thermometer with you, then as high temperature as possible, but not to burn yourself, okay, or cause scarring lah. Okay, that is to send to hospital immediately. So remember, for this case, do not apply pressure immobilization, okay? So when you reach hospital, okay, have this box jellyfish in certain hospital, okay, it is anti-venom, okay, only apply to the multi-tentacled box jellyfish or the chironex species. So what is the indication? It's when the patient have life-threatening systemic symptom like cardiac arrest, respiratory failure, cardiac arrest, arrhythmia, or unconsciousness. But in situation where patient has intractable pain, severe pain, okay, despite giving opioids, magnesium sulfate, okay, and also your hot water immersion, patients that have pain, there's also indication for you to give box jellyfish, box jellyfish antivenom. All right. So how about the single tentacled box jellyfish? Okay, that cause Irukandji syndrome, the catecholamine like syndrome. There's no antivenom for it, so no role of you giving fish antivenom. Okay, we just give supportive care. So if the patient having severe, you give opioids, you can also try magnesium sulfate. If the patient nausea and vomiting, you just give Maxilon. Agitation, you can give some benzodiazepine. And if patient have hypertension, then you can give nitroglycerin, okay, and or phentolamine. But if you remember not to give beta blocker because it will cause unopposed alpha action. Then next mechanism of marine envenomation is actually bites. So under this group of bites, we have the octopus and also the sea snakes. Okay, so I will start with sea snakes. So sea snakes, we have two types, the true sea snakes or hydrophinae, or the Lauticaudinae, which is the sea kraits. Okay, so the true sea snakes, actually, they already modified their body to really adapt into, for them to survive inside the water. So by having this tapered tail so that they are able to swim, okay, like ribbon like, they are able to swim in the water. Okay, they also have this nose or the snout, okay, at the tip of their, on top of the tip of their head, okay, because they do not like fish which have gills. They still have to surface upon the water to breathe. Okay, and for the sea crate, okay, they are able to actually go to the land, so they have actually thickened ventral scales lah. Okay. Then what are the effect of this Elapidae sea snake? They can actually cause myotoxicity. So for the skin lesion, because these sea snakes, they have very small teeth, so the lesion that they cause when they bite on the body, okay, they do not have this very typical fang-like lesion, okay, because of the very small teeth. But they can cause myotoxicity. The patient can have severe pain later on, not on the bite. Okay, they might not be aware of the bite, but the severe muscle cramp and also muscle pain will happen later on. Okay, and the patient might have rhabdomyolysis. Okay, and also myoglobin in the urine. So the urine will look red in color. Then what we are afraid most also is neurotoxicity, when patient can go into respiratory distress or depression. Okay, the first sign of neurotoxicity is ptosis. Okay, so it's very important for you to check for ptosis, okay, in order for which is the early sign of neurotoxicity. Okay, so we have to send this patient immediately to the hospital, and in this case, there is role of doing um, pressure bandage immobilization, okay, and send the patient to hospital, because we do have sea snake antivenom available if the patient develops systemic envenomation. Okay, there's also rule of urine alkalinization, okay, to prevent the severity of rhabdomyolysis. So you can alkalinize the urine or make sure that the urine output is good, okay, so to wash out the myoglobin. Okay, next is we have this octopus. So octopus, among these octopus, what we are worried most is actually this this blue ring octopus. Okay, so blue ring octopus is actually small. Okay, you can see it's actually very small in size. Okay, but it's very deadly. Okay, so you can see here when this is a very beautiful creature. Once it is disturbed, okay, you get angry, then the blue ring actually will illuminate, okay, it brightens up. Okay, so this blue ring octopus, it doesn't sting you, but when it bites you, the saliva actually can cause toxic envenomation. Okay, because the saliva contains toxin, which is a sodium channel blocker. They are not aggressive and they will only bite when being disturbed. So what is the effect? Okay, so for the local symptom, it will cause just minimal pain, but it can cause systemic envenomation, which is caused by this toxin, which the patient can result in generalized paresthesia, okay, nausea, giddiness, and malaise. Okay, patient can even have a neurotoxicity, which is flaccid paralysis and also respiratory failure. Okay, so how do we manage? We also do not have antidote or antivenom for this. Okay, we can apply pressure immobilization. Okay, and patient, if develop paralysis, then we have to give supportive care. We have to make sure that the airway is patent and we give ventilatory support. Okay, remember to update your tetanus status. Okay, so remember that it is not only venomous, because of this toxin that is available in the body. Okay, consume it, it can also be poisonous. So be aware when you buy octopus outside. Okay, when you want to eat, make sure there's no blue ring on top of it. Okay, it's like the pufferfish, which has this tetrodotoxin. Okay, so how to manage marine envenomation? So this is the summary. Blue ring octopus, okay, local symptom is usually painless like sea snake, but it can cause neurotoxicity like sea snake. Sea snake can also cause myotoxicity. So both you can apply pressure immobilization, you give supportive care, and there is anti-venom for sea snake. Okay. So for stings and spines, okay, we go to the stinging fish. So we got various type of fish that can sting, okay, like for example, catfish, stonefish, lionfish, and also scorpionfish. Okay, so out of all this, the most venomous or most dangerous one is actually the stonefish. So you can see the morphology of the stonefish. It can actually you might not be aware of it because it camouflage very well with the seafloor. Okay, it really look exactly like a stone. Okay, but so this stonefish actually it will just be on the seafloor. Okay, it well, if you aware of it and you step on it, okay, this will really happen, okay, because they have this the dorsal spines, okay, have these venom glands. So when you step on it, okay, you steps on you actually compress, okay, on the when the integumentary sheet is being pushed down, it stimulates the venom gland. Venom can actually be excreted out. Okay, so other than causing very severe pain because of this penetrating injury, you can also be envenomed. All right. So same thing goes to lion and scorpion fish. They also have these spines at the dorsal fin. Okay. So you can see when you press the spines, okay, that it will inject the venom. Okay. So what are the symptoms? Okay, so for the local envenoming, it causes very intense pain, okay, excruciating pain. Then it also can cause progressive swelling. All right. Then next, what we are worried most is actually systemic envenoming. Patient might have pulmonary edema, hypotension, dysrhythmia, and also neurotoxicity, muscle weakness, and paralysis. Okay, and for this, all this marine penetrating injury, what you have to worry of is also the side effects of infection because patient might end up with necrotizing fasciitis, okay, or due to the infection caused by marine infections due to Vibrio uh, vulnificus or errors. So how to manage stonefish envenomation is first you have to recognize case the mechanism of injury. Most likely, okay, this is stonefish. Okay, then you can immerse the food, for example, if the food is affected into the hot water. So same thing, 42 to 45 degrees Celsius for 30 to 90 minutes, okay, until the pain subsides. Then you can transfer to the nearest medical facility because this stonefish can might cause envenomation. So same thing, you will give tetanus toxoid, you cover with IV, okay, to add that is to avoid lah, okay, the complications of marine infections. Okay, so the first 48 hours, you can actually give doxycycline. You can also give uh, third, um, third generation cephalosporin like ceftazidime. Okay, you also can give clindamycin or ciprofloxacin. Then for pain management, you can give analgesic. Okay, sad to say that we do not have anti-venom here in Malaysia. All right, so you can only give supportive care for the patient. And what hot water immersion also proven that it can denature the toxin. Okay, next we will go to stingray. So stingray is um, a big marine creature. Okay, it it likes to actually embed itself, okay, in the sand. Okay, so if you are not careful, you can actually step on it. All right. So the where is this this stingray? Where does the venom actually locate? Is actually at the tail. Okay, so at the proximal part of the tail, you have this bud. Okay, so this bud actually can other than cause penetrating injury, it can also cause insignificant envenomation lah. So very famous Steve Irwin, which is a wildlife master. Okay, he was killed actually by stingray at the age of 44. So this bud actually, the bud of the stingray or the tail, okay, actually penetrate into his trunk, this his chest, unfortunately, and this caused death. So if just like other penetrating injury, okay, it can cause severe wound, okay, penetrating wound, cause bleeding, it can also cause infection. So it's very important for you to manage the wound and ensure that there is no embedded foreign body or bugs still inside the body. Okay, so you have to do X-ray or ultrasound to rule it out. Okay, then because if the bud or sheet with venom is embedded into the muscle, okay, it can cause muscle necrosis. It can also result in chronic infection, including bone osteomyelitis infection. Okay, next so how do you manage the wound? Okay, other than remove the foreign body, we have to ensure that proper debridement is being done. Okay, so it's good also to leave the wound open. Okay, you clean daily and allow for delayed primary closure. You don't have to suture immediately. So this is the infection that we worry most, okay, which is the necrotizing fasciitis. Okay, so you have to cover with all these antibiotics, okay, to prevent this fresh eating bacteria from causing sepsis because the mortality rate is very high. So just like what I've mentioned, okay, the hot water immersion, okay, is really helps in stinging fish and venomation, stinging fish to reduce the okay, and also to reduce the rate of systemic envenomation because it does deactivate the toxin. Next, we will go to cone snails. Okay, so cone snails also can sting. Okay, so we have the mild. It causes mild local symptoms, it's painless, but it can actually cause paralysis because it do have this paralyzing neurotoxin. Okay, so how it actually deliver the toxin? Okay, you can look at this video. Okay, so this all right. Okay, so basically these cone snails, they have siphon. Siphon is like a detector, okay, to see whether there is prey nearby or not. So if there is, then this it will come up, the proboscis will come out. So this proboscis that is protrude out actually has this hidden harpoon in them. So this harpoon will deliver the venom, which is 1,000 times, okay, more more poisonous than cyanide, okay, and will cause toxicity, paralyze the prey, and then after that it will just withdraw, pull the prey into the rostrum or the mouth and engulf it. Okay, so how do we manage corn snails and venomation? Is by applying pressure bandage immobilization so that the venom will not travel fast, okay, and cause systemic envenomation. Okay, then we can also do hot water immersion. We can do symptomatic treatment. Okay, if there is any pain. Okay, but the pain is not severe in this case. Okay, what we are worried most is actually paralysis. Okay, so if patient go into respiratory depression, then you intubate the patient. Okay, there is no anti-venom for this cone snails and venomation. Next, we go to sea urchin. Okay, so this sea urchin, it has small spiny globular animals. It has spikes on its body. So just like starfish. Okay, it can actually cause pancreatic injury. Okay, the bags can actually be left on your skin or your body, and you have to remove it as much as you can because it can cause edema, pain, okay, pruritus, and also bleeding. Okay, if you leave it there, it will cause wound tattooing. If it's at the joint, it can also cause infection, synovitis, and secondary wound infection or granuloma formation. So systemic symptoms is rare, but it's possible, okay, such as nausea, vomiting, paresthesia, and muscle paralysis, and respiratory distress. Okay. All right. So to ensure that there is no more foreign body embedded, you have to do X-ray or you can do ultrasound. All right. Okay, so what is the treatment? Okay, you have to remove the broken all spines from the body, can do hot water immersion for pain management. Okay, you can also apply vinegar or 5% acetic acid. This is not to deactivate nematocysts. This is just to dissolve the spine is trapped in the skin. Okay, so if it is large, okay, it's difficult to remove, you can also can do surgical removal lah. Okay, so in summary, okay, marine animals that can kill you in one hit are all this. So we have corn snail, we have stonefish, we have jellyfish, the box jellyfish, we have sea snake, and we have the blue ring octopus. These are the venomous one, okay, highly venomous one. So the take-home message for today is remember that you might step on this stonefish, so wear shoes protect your feet from being being injured by venom. Then bring along vinegar if you go to the beach, okay, go to the sea. All right. So there's no role of urinating on the jellyfish thing, thinking that it will actually deactivate the nematocyst. There's no role. Okay. Then there is role of hot water immersion in a lot of these um, marine envenomation. Okay, so be aware of the signboards, okay, along the beach. Okay, if okay, the authorities should actually use this netting so that can filter out all these harmful jellyfish. Okay, we'll have to send the patient to the doctor as soon as possible because we do have anti-venom available. Okay, and some of these cases actually end up with life-threatening neurotoxicity, for example, and they require okay, and also supportive care. And we do have anti-venom in the hospital for sea snake and also box jellyfish. With that, I thank you. I end my presentation here.
Thank you very much, Dr. Yon, for that comprehensive and insightful presentation. I'm sure all of us gain a valuable knowledge on managing a marine envenomations cases effectively. Okay, we'll now open the floor for any questions. Dr. Yon, in the chat box, there is a question from Dr. Amar Faiz. For offshore operation, it is important to have an anti-venom on board for sea snake.
For offshore operation, you mean if for healthcare workers or not? Okay, I will answer the second question first. So for Sabah, Sarawak, which hospital has anti-venom? Okay, so in okay, I'm from Sabah. Okay, so I can tell for Sabah. So for Sabah, for example, Semprona, Tawau, Ladatu, Sanakan, and also Likas, we do have seasoning antivenom as well as box jellyfish antivenom. Okay, then for offshore, if you have certified healthcare worker and you have enough of money to procure all this antivenom, then why not you have it? But it's actually not common. It's recommended, but whether you have the you know the indication, you have the expertise to deliver the antivenom, and whether you have the stock or not. Yeah.
Okay, okay, thank you, Dr. Yon. And we move on to the second questions. How common are the sea snakes toxic available in Malaysia? And there is any alternative if the antivenom is not available?
If the antivenom is not available, you can do supportive care. So just now, like for rhabdomyolysis, okay, you ensure that you hydrate the patient properly, okay, to flush out the myoglobin, okay. Then also um, supportive care only, no? Mm.
Okay, fine, Doctor. So we move on to the
Yeah.
third question. What is the time frame from the sea snakes bite to the hospital to emergency?
Okay. Snake, it can be a bit slow acting, okay? Time frame, I will just say you go to the hospital as soon as possible. But if arrive at hospital, how long you want to observe? So if the patient will develop systemic envenoming, it usually will occur within 12 hours. So it's good that you observe the patient for over 24 hours. If nothing happened, then you can discharge. Okay? Yeah. Do I answer your question?
Yes, Doctor. Okay, then we are more on the next question. You mentioned the hot water immersion is a good for marine envenomation, but what if the sting is a large area like the abdomen or thigh? How do we apply it safely in that cases? Is it the patient need to be take bath?
Okay. Okay, so yeah, if you have the facility, okay, you can actually uh bathe lah, okay, with hot water.
Oh,
Mm.
all right, thanks. And we move on another question. For cornfish envenomation, how is the venom being neutralized?
The venom can be neutralized by doing hot water immersion.
Same, okay. And one, um, we realize the most marine elimination presented earlier, part of the management is a compensation bandage. However, we are not advised to do so for other envenomation. Why is the distinction is different management treatment? Thank you.
However, we are not advised to do so for other envenomation. You mean marine or
Land.
terrestrial animal? Okay, so for example, I answer for marine lah. Okay, so just now we talked about different types of marine animals. Okay, it can deliver the venom via nematocysts, bites, or stings. Okay, so like for example, box jellyfish is through nematocysts. So we do not encourage this pressure bandage and immobilization is because if you apply pressure on it, it can actually activate the nematocysts from firing, so it will cause more severe envenomation.
Okay.
So if you see the typical multiple tentacle whiplash lesion on the skin, you don't apply pressure on the skin. Okay, but if like sting, all this, okay, if the patient tell you, okay, I was bitten by sea snake, um I step on something, okay, you do not know what is it, but it's definitely it's not jellyfish, and it's good that you apply pressure immobilization lah. Okay.
Okay, we move on the last question, doctor. How do I know what type of jellyfish stung a patient? If the patient unable to describe the jellyfish, how should I monitor the patient ED?
So how do you know the type of jellyfish thing? Okay, so um usually the typical multi Okay, just now I mentioned few types of jellyfish, right? So the
Yeah.
most worrisome one is actually the multi-tentacled box jellyfish, which is caused by the chironax species. So
Mhm.
this chironax species is cause very typical whiplash lesion, okay, on the skin, multi-tentacled lesions, okay. So this kind of patients, if the skin lesion is significant, just like your burn, you count the body surface area. So if it is significant, you have to observe the patient for a longer period of time, okay? So if systemic envenomation were to occur, it will occur within 6 hours, I would say. Then how do you know which type? But not necessary is caused by chironax species. So how do we know that it's which type? You can actually do the nematocyst sampling. Okay, so the nematocyst sampling is you just apply cellophane tape, okay, it on the skin lesions here, which have the skin markings. Then you can look under the microscope and see whether by looking at the morphology of the nematocyst, okay, hopefully you can able to sample the nematocyst and you are able to see under the microscope. So the morphology of the nematocyst actually can tell you which species it is. So for example, Physalia physalis, it is actually round. Then the box jellyfish, it is actually elongated. The chironax one is elongated. Um, there are morphology that you can identify. So you can always consult experts okay, to help you identify.
All right. Thank you,
So how
Doctor.
should you monitor the patient? So one is you monitor the pain score. Yeah, and also for cardiorespiratory arrest symptoms.
Thank
Okay,
you.
that's all.
Thank you very much, Dr. Yon.
Mm.
Okay, now we will move on the second topic of the day, poison by the sea. It is my pleasure to introduce our second speaker, Dr. Emilia B. Santa Maria, an emergency physician and disaster medicine expert, currently based at the Lion B. Johnson Tropical Medical Center in American Samoa. Dr. Emilia is widely recognized as a pioneer and leading advocate in advancing clinical toxinology in the Philippines. She obtained her Doctor of Medicine from De La Salle University and completed her emergency medicine residency at the Philippine General Hospital. The latter pursued and earned her master's in the disaster risk management from Batangas State University. Dr. Emilia is a founding member of the Philippine Toxinology Society Incorporated and has been instrumental in leading numerous national and regional training invited on snake bites and marine envenomation management. She is also actively involved with the Asian Remote Envenomation Consultancy Service, the Philippine College of Emergency Medicine, and the Health of Emergencies and Disasters Study Group at the National Institute of the Health, University of the Philippines, Manila. Her areas of interest include emergency medicine, clinical toxinology, EMS systems, disaster medicine, and public health. She has co-authored several research publications in these areas, and currently she serves as a lecturer at the UP Manila Disaster Risk Reductions Management for Health Center. We are truly honored to have her with us today to share her expertise and regional perspective on marine envenomation and poisoning. Please join me in welcoming Dr. Emilia V. Santa Maria for her talk entitled Poisoned by the Sea.
Okay, thank you very much for the kind and generous introduction. So, I have asked some of my colleagues to help me with my slides because being a Gen X, I am I am technologically challenged a little bit, and then I
Yeah.
asked them to yeah, that's right. Okay, thank you very much, Owen. Okay, so for our objectives, I'll just give you a short overview of the marine envenoming and poisoning, and discuss about the following. So this is quite new for me, and I was studying how it's going to be pronounced, but it says it's shellfish. So that's turtle meat poisoning, okay? And ciguatera poisoning as well. Most of you are quite familiar with this. And this cyanide fishing and fish poisoning that I myself has been just really new to this topic until I had a patient who presented with signs and symptoms of cyanide fish poison, cyanide poisoning. Okay, so we'll discuss it a little bit later on. Okay, next slide, please. Okay. So in this slide, I want you to, sorry, can you go back, please? We need to always be aware that we are mere visitors in the ocean, especially. So this is their home. So there's always a need for us to respect their home, just like what we expect when people visit us in our home, right? Okay, so next slide, please. So we just want to enlighten you again, or like just a review about envenomation and poisoning. So we need to have a very clear understanding of what is envenomation and poisoning. So when we say there is envenomation, so there should be an exposure to an animal's toxic secretion, generally known as the venom. And this is usually sustained after a bite or a sting. While poisoning, on the other hand, is caused by an exposure to a harmful substance through ingestion. Take note, there should be an ingestion or swallowing or injection or injecting, breathing it in through inhalation or touching. Okay? So keep that in mind, because sometimes until now we are able to hear some people referring to snake bite poisoning, something like that, which is for us in the medical field, we should be very careful on how we present these cases. Next slide, please. So just a short review again. Marine creatures that cause envenomation are usually the invertebrates. So there are the families which is Cnidaria, which includes the fire corals, the jellyfish that has been discussed earlier, the mollusca. So there's the cone snails under the gastropoda, and then cephalopoda, which is the blue-ringed octopus. And we also have the sponges and echinoderms, or what we refer to as the sea urchins. That is very common injuries that are observed in our clinics or resorts. Next slide, please. And there are other creatures which are referred to as vertebrates. And these are the stingrays, lionfish, stonefish, the scorpionfish, and the sea snakes. Next slide, please. All right. So as earlier mentioned, there are types of marine envenomation, and they can be penetrating envenomation caused by the organisms or the sea creatures that has been mentioned earlier. Okay. And non-penetrating envenomation. So this is usually when we touch them or we get sting or get stung. And then so these are the fire corals or hydroids and the jellyfish that has been also discussed earlier, as I have mentioned. And of course, the super deadly, as we all know it to be, so the box jelly. So the Chironex species, the Caribbean species, and of course, the Australian Carukia species, causing the Irukandji syndrome, which really gives us a lot of pain. And for marine creatures that cause poisoning, so we have the Ciguatera fish poisoning, which we will be discussing, as well as the histamine scombride fish poisoning. So what are the vectors? Next slide, please. So, and another one that we need to mention would be the chelonitoxism, which is the turtle meat poisoning. So this is quite important. So let's proceed to the discussion of Ciguatera fish poisoning. So this is a form of what we call ichthyotoxicosis. Normally, it's caused by consumption of many species of tropical and subtropical reef fishes from the Indo-Pacific and Caribbean Sea. And this is usually caused by ciguatoxin. So these fishes are contaminated by what we call ciguatoxins. So what are the vectors of the Ciguatera toxins? Usually, they are the moray eel, barracudas, groupers, jacks, and amberjacks, and snappers. These are common fishes that are observed to be vectors of the Ciguatera toxin, as well as the surgeonfish, the parrotfish, the rhesus hogfish, narrow-barred mackerel, the Spanish mackerel, which, we usually have as sardines for our food. Many people have Spanish mackerel as their favorites, so we have to be very careful. And two other fishes would be the trevally and the triggerfish. So as we can observe in this picture, so the Ciguatera toxins are produced by the microalgae called the Gambierdiscus toxicus that can grow on seaweeds, dead corals, and other surfaces. So the small fishes eat this toxic algae while grazing at the coral reefs, and the largest fish accumulate the toxins by, of course, eating the smaller fishes that have already ingested or eaten the toxins. So as we can see here, the more common ones that are responsible for this poisoning would be the snappers, groupers, the barracuda, and the amberjacks. So usually, what are the clinical presentation of this Ciguatera toxin poisoning? So we will observe neurologic, gastrointestinal, and cardiovascular symptoms. And of course, so we will note like there's complaint of pounding headaches and ataxia, and there's the what we call hot feels cold, or and these symptoms are also included in central and peripheral nervous system symptoms. So there will be swelling of nerves and destruction of it as well. And then there will be like fatigue and myalgia, and of course the increased excitability of nerve terminals responsible for already unable to tell if it's hot, or the hot feels cold, the cold feels hot. Okay, so these are the things that we observe in some of these patients. So what do we do as pre-hospital management? So it's always important that we should recognize these life-threatening conditions. So we will be able to see, as I've mentioned earlier, there will be respiratory distress from the neuromuscular paralysis that happens, and of course, you will also observe some form of bradyarrhythmia. And then what should we do about it? Of course, we stick to our ABCDs, and of course, we will also be able to monitor the heart rate of these patients, and we will start, hydration with ORS solution, and we make sure that we clear the secretions from the hypersalivation that is observed, and we can use the fluid resuscitation, 2 cc per kg for severe dehydration and unobserved hypotension. So what are the definitive management for Ciguatera fish poisoning? As I've mentioned, we really have to stabilize them by giving them atropine for bradycardia. And we may also consider inotropes or temporary pacing if there's if it is refractory, and we need to monitor the hydration and electrolyte balance as well. So we make sure that we order the necessary laboratory workup for these patients, and make sure to get them on as quickly as you can, so that we may be able to address the issues accordingly and immediately. So we can do decontamination. If the patient arrives within 1 to 2 hours, then we can still consider single dose activated charcoal if there was ingestion of large amounts of these fishes. And we should avoid antiemetics at this with these cases. So unfortunately, there's no antidote that's available, but there's also a reported response to mannitol, giving of mannitol at 0.5 to 1 gram per kg over 30 to 45 minutes within 72 hours. However, we should always do this with caution. Okay. Now we proceed to this a little bit new, although it's really not new because it has always been present as early as the 1800s. Based on one of the texts that I was able to read. It has been observed in the Caribbean and other African countries. One of the reports that I have recently seen on the news was an incident in Zanzibar. Okay, so chelonotoxism or chelonitoxicity is a type of food poisoning after consuming this sea turtle meat, and it is contaminated with what we call the chelotoxins, thought to accumulate from the environment. This is like from the toxic algae that are eaten by the turtle, but the turtle itself is not affected. So 62 incidents have been reported, but this study was done in 2024, and recently there has been reports of more incidents of chelonitoxism, and reported number of victims were about 2,400, and unfortunately 420 cases succumb, or we can classify them as fatalities from chelonitoxism. So apparently one of the causative agents that they have implicated was the Limbia toxin. However, there's really very limited evidence that we can associate it to the chelonitoxism, and really blame this toxin for this food poisoning. And usually they really accumulate through the food chain. Okay, so as we all know, sometimes these algae are just the main food of these turtles, and then these turtles get caught, and traditionally they have been eaten, and I believe that there's still some in some other places there's also still a delicacy. So it's really important to be aware of this food poisoning. Okay, so what do we observe in this chelonitoxism? So they start to feel burning in their mouth, and burning throat sensation as well, with associated epigastric pain, diarrhea, vomiting, and this other issues are observed, such as the ulcerative esophageal duodenal lesions. However, when there is already neurologic, hepatic, and renal toxicity, the patient really presents with other signs and symptoms that really needs hospitalization, and a lot of them succumb. When they end up in the hospital, most of them, succumb and die. So, what are the things that we can do for these cases? So still, we need to stabilize, and still really bring them to the hospital right away, because these are the cases that need respiratory support and ICU care. Unfortunately, as again, we don't have an antidote that has been established for these kinds of cases. So, what do we do as like some form of education for these people? Next slide, please. So, we tell them really not to eat this turtle fish. Oh, sorry, turtle meat. Okay. So we proceed to cyanide fishing and poisoning. Apparently, cyanide fishing has been done as early as the 1940s, and this is actually like it involves spraying a sodium cyanide mixture into a habitat to stand the fish for capture. So they just become weak so that these fishes can be caught. And unfortunately, some of them end up dying. But when they recover, they are the ones that are caught by the fishermen, and then they use this for live fish. When we eat in some live fish markets, that we choose the fishes and all these things, all those premium food that we have in the markets, and that's when the poisoning happens. So this practice not only harm the target species, but they also harm the coral reefs and other marine organisms. So it's really a very highly destructive and illegal until now, but still it's being done, unfortunately. Okay. So next slide, please. So we need to be very careful about these cases, because as we all know about what cyanide does to our body, for the fishes in this case, it affects their performance. So meaning like they become weak, and then that's the time that the fisherman catches these fishes. So they cause cytotoxic anoxia via the inhibition of the enzyme cytochrome C oxidase, so scientific, and prevents the mitochondria from using the oxygen in the electron transport chain. And of course, we all know what metabolic does to our body, which is usually due to the lactate accumulation. Okay. So it's highly toxic, as we all know, not most especially to humans, and we really make sure that we will be very careful when it is being used. So these fishermen are aware of what to do when they do this illegal fishing. So they say that aside from the accidental ingestion, usually cyanide poisoning can result from the inhalation of the gas, hydrogen cyanide. So this deadly gas can be produced by accidentally spilling the acid on the sodium cyanide. So adequate and relatively inexpensive gas mask can be your PPE, so that you will be protected from inhaling this gas. And also, cyanides are also capable of being absorbed through the skin. So remember earlier that was mentioned that you can also get cyanide issues, cost issues when your skin is also affected. So what, as I mentioned earlier, their performance. So what happens to these tropical reef fishes? So they can see they can show respiratory distress fishes, and then of course they will have damage also. So there will be reduced swimming capacity for these fishes, and of course they will not grow anymore. And then those who survive, which survives, the fishes which survive, they of course cannot reproduce anymore, and eventually they die also. And so what do we do? Usually, the ones that are affected with cyanide poisoning, as we have already observed in our emergency rooms, would be presenting with general weakness, malaise, and usually they have collapsed at home or en route to the hospital. So what do we observe? So there's like progressive hypoxia, headache, vertigo, dizziness, giddiness, confusion, generalized seizures, and then they may come in coma. And the gastrointestinal symptoms that has been observed they present with nausea, vomiting, and of course abdominal pain. And they can also be observed with onset of shortness of breath and associated with the chest pain or apnea that we can observe when they present in the ED. We will remember because when we were in our during our residency training, cyanide poisoning was usually observed in patients who have ingested silver jewelry cleaner. It has been already banned, and this silver jewelry cleaner was subjected to a law for them to change the components of this cleaner and remove the cyanide content. So that was how this poisoning has been addressed about 10-12 years ago. Okay, next slide, please. So the most important thing to do with cyanide poisoning would be stabilization. Actually, bring the patient to the hospital right away. No staying and playing. Just bring the patient to the hospital, because they will definitely expect, or they should really have like they will really need respiratory support, and then eventually for sure an ICU care. So it's very important to bring this patient right away to the hospital. Okay, so fortunately for cyanide poisoning, we have an antidote. We have an antidote that is first line, and other antidotes as well. So the first line antidote would be the hydroxycobalamin. We have it as what we call the cyanokit. Some centers are fortunate to have this. So the standard dosing is 5 gram administered intravenously over 15 minutes, and you can give an additional possible 5 gram dose depending on the response of the patient. Okay. The other antidotes, next slide, please, would be the sodium nitrite and the sodium thiosulfate. So this both are given intravenously, and for adults, the dosing would be 10 ml of the sodium nitrite at the rate of 2.5 to 5 ml per minute. And followed, this sodium thiosulfate should be given immediately following after the administration of sodium nitrite, and giving giving 50 ml. And for children, it should be 0.2 ml per kg, or 6 milligram per kg, or 6 to 8 ml M2 for body surface area. Okay? So they can be given at the rate of 2.5 to 5 ml per minute, and not to exceed 10 ml. For sodium thiosulfate, on the other hand, we can give 1 ml per kg of body weight, and not to exceed 50 ml, and the total dose should be given immediately following administration of sodium nitrite. If I remember it right, like, before when we were in training, the moment you are able to give this right away or like immediately, it's really dramatic. After a few hours, this patient is trying to remove their ET tubes. They're trying to self-extubate because they're like awake, and then like they can they will be like, what happened to me? They will be like, what, why am I even here? So the importance of giving this antidote is really, really very important. The time that this the immediate treatment or the immediate giving of this antidote really gives you a very dramatic recovery. So I think in all centers, major centers, major poison centers, this is very important that this is always available. Okay? So in summary, what do we do with ciguatera when there's ciguatera fish poisoning, when we have shellfish, and when we have cyanide fish or fish poisoning? Please just remain calm. That's the mark of a true emergency physician. Do not panic, and keep in mind the basic principles of the marine poisoning, and remember the clinical manifestations and the treatment. And of course, as we can never really stop saying, we need prevention and education, and we need to make sure that these people that we meet, especially when we do our community teaching or community education, let's also mention these things, especially when you go to the coastal areas. And of course, please stop eating sea creatures like turtles and fishes that we already know can cause poisoning. And of course, one of the most important thing that we have to learn or keep teaching, because that's how we are able to keep ourselves updated, is, next slide please. Of course, we need to have the skill, the skill to do CPR, which is now what we usually teach nowadays is the hands-on CPR, especially after the pandemic. So we always have to make sure that wherever we go, if we have the time, just keep on teaching CPR to those people who are very interested or really interested in knowing how to do the hands-on CPR. As medical students, I think you have already undergone basic life support training, and how do you how I mean what is the best way to teach or remember something? Of course, we need to learn and then do one and then teach one. Okay, so that has been my advocacy since after I finished my residency training. I always make sure that whoever wants to learn CPR, just teach them. Start with your family members, and you will see how interested they really are. Because someday it may be you that they will save, not you saving them. Okay, so terima kasih. Thank you very much for your attention, and for our upcoming Congress. I am so eager to invite you guys. The abstract submission has been adjusted. Can you come back? Can you go back to the last slide, please? Sorry, our Congress, please. Yes, the next one. The last slide. Second to the last. Yeah, then yeah, yes, this one. So please come. We will be happy to host you in Palawan on December 3 to 5. So it's gonna be our first Philippine Toxinology Congress and the 6th International Symposium of the AMSEM, or ASEAN Marine Animals and Snake Envenoming Management. So we would be very happy to see you there. You can scan the QR code or ask anyone, any of your organizers today. I will be leaving this posters with them, and hopefully we will see you there. Okay? Terima kasih.
Right, Dr. Emilia, thank you very much, Dr. Emilia Santamaria, for that enlightening and comprehensive presentation. Doctor, we will move on the questions in a forum QA session. Is it okay?
Okay.
Okay, Dr. Maria, we'll see you later.
The challenges. This is one thing that is quite unusual about American Samoa. Fortunately, we don't have snakes.
Oh,
Yes. And for sure, there are sea snakes, but people don't really go that far to meet some of these sea snakes, because I think even if there's no snakes, land snakes in American Samoa, because we have the sea, I think the sea snakes can still be found. But I have not encountered any case of sea snake bite, fortunately. And for the anti-venom and antidote, we don't have anti-venoms as expected, because for snakes, because we don't have snakes. And then what else so antidote for the turtle meat kilonitoxism, I haven't had any case that presented to RED. Ciguatera poisoning, there were quite a few, because we have all those fishes that have been mentioned, the barracuda, the snappers, and the groupers. These are common fishes out there. But fortunately for us, as I've said, we don't have snakes. So I was telling Dr. Cal, we don't have snakes back in American Samoa. So yeah. So that is quite of an interesting fact for me until I got there. I didn't know that there were no snakes in American Samoa until I got there.
okay, Dr.
Oh, I'm sorry. I'm saying that I got there because I'm still halfway through my travel getting there. I'll be there soon.
Okay, thank you, Dr. Emilia. We'll see you on the forum QA session.
Okay.
All right, see you there. Thank you.
Okay, bye-bye.
Bye.
Terima kasih.
Sama-sama. Welcome back. Okay, now we are move on to the our third and the final topic of the day: shellfish-related poisoning, paralytic shellfish poisoning. It's given me a great pleasure to introduce our next speaker, Dr. Siti Noor Izni with the Sheikh Muhammad Amin, who is currently serving as an emergency physician at Hospital Port Dickson. Dr. Siti obtained her Doctor of Medicine degree from Universiti Kebangsaan, Malaysia in 2010, and later completed her doctorate in emergency medicine also from UKM in 2021. In addition, during her master programs, she conducted an insightful research study on health-seeking behavior following snake-related injuries, referred to the Remote Innovations Consultancy service between 2019 and 2020. He has presented a case series on mussels poisoning in Port Dickson at the Snake Envenomation Management and Marine Envenomation Poisoning Conference 2024 in Sandakan, Sabah. Her clinical experience and research background have greatly contributed to our work understanding of marine and toxic-related emergency in Malaysia. We are pleased to have her with us today to share her knowledge on this important and locally related topic. Please join me in welcoming Dr. Siti Noor Izni with the Sheikh Muhammad Amin for her presentation entitled Shellfish-related poisoning, paralytic shellfish poisoning. Dr. Iziti?
Okay. Assalamualaikum and a very good morning. Can you hear my voice?
Yes, I
Can you
can
hear
hear
me
you.
clearly? Okay, I shall share my screen. Before
Yes.
that, I would like to say thank you to the organizing committee who inviting me. So today I'm gonna talk about shellfish poisoning, in particularly paralytic shellfish poisoning. Okay, can you see my slides?
Yes, doctor.
Okay, so the titles is Types of Paralysis and the Hidden Peril of Shellfish. Okay, so this is the outline of my presentation. So before we start, actually my approach to presentation is a bit different. So I'm going to start with clinical presentation first. Okay, so last year in Port Dickson Hospital, so I'm working as emergency physician in Hospital Port Dickson. So last year we received a cluster of outbreak. So this is actually first time managing shellfish related poisoning. And we start with the first case. Okay, first case was on 31st of March 2024 last year around 8 p.m. So we have a 28 years old male with underlying history of bronchial asthma. He presented with multiple onset of generalized tonic-clonic seizures since 6:30 p.m., actually treating as status epilepticus. Upon arrival to emergency department, he has been continuously feeding and aborted with intravenous diazepam. We have completed, the patients completed phenytoin loading dosage and the seizure stopped, aborted. The patient was intubated for airway protection. However, we realized that systemic examination are remarkable apart from altered mental status. So the blood parameters and ECG actually normal, no long QT or procuras complex to suggest poisoning. Blood gases shows respiratory, mainly respiratory acidosis with mixed metabolic component. Bedside urine toxicology were normal, and we sent the patient for imaging CT brain as per protocol because patient we have no significant cause at that point of time. So CT brain shows no significant findings. So the patient was admitted to intensive care unit and treating as status epilepticus for investigation. So this is the first patient. Okay, move on to next patient. Few hours later, we receive another neuro patient, 62 years old male with no underlying illness. He presented with sudden onset of upper and lower limb numbness bilateral while performing Isha prayer around 9:30 p.m. So upon arrival to the emergency department, the medical officer who attended the patient realized that there is generalized weakness and numbness together with presence of slurred speech with unsteady gait. Apart from that, other systemic examination were unremarkable. Parameters were also normal. Again, we sent the patient for CT brain because the impression at that point of time possibility of having posterior circulation infarct. And again, the report shows acute infarct may not be manifested within first 24 hours. So typical findings. So the patient admitted to general ward. Okay, and then we have our third patient in the same night shift. 20 minutes later, 64 years old male with underlying diabetes mellitus, high blood pressure, and dyslipidemia. So the patient presented to ED referred by Klinik Kesihatan for hypertensive urgency. He has sudden onset of perioral numbness, bilateral upper limb numbness at 9 o'clock. And then the blood pressure shows hypertensive, 240/131, not tachycardic, SpO2 is 99, sugar is normal. There is significant reduced sensation of a bilateral upper limb. And again, ECG were normal. And the patient also was sent for CT. The CT was normal, CT brain plain. So the patient was admitted to the general ward treating as hypertensive emergency with treating as stroke. All right. So we have the fourth case. Okay, the fourth case is actually daughter of this patient who came the next day around 3 p.m. So the daughter is 22 years old female with no comorbidities. The patient was triaged to L4 early care zone. So presented against similar symptoms as her father because she is a bit anxious because the symptoms occur a bit later than her father, and her main concern is that, am I going to have stroke like my father in the war? All right. So there is quite significant elevated of blood pressure here, 160/94, tachycardic. Otherwise, only significant findings were reduced sensation of a bilateral upper limb, and the rest is normal. So she is the daughter of patient number 3. So upon further history taking, the patient mentioned that she ingested mussels 2 hours before the presentation. So when we asked further, apparently patient brought the mussel from the local market in Port Dickson, and the mussel actually being harvested from one of the, if not mistaken, Kampung Teluk Pelando in Port Dickson. Okay, so this lady with such history, we think is there possibility related to shellfish poisoning, because the onset of ingestion 2 hours later than only the symptoms present. So this case was consulted to state toxinologists, and clinical diagnosis of paralytic shellfish poisoning was made. And then another patient came 1 hour later, have same presentation as well. 42 years old male with no comorbidities, triage to level 3, presented with sudden onset perioral numbness. So the patient, like 1 hour after, with bilateral upper limb weakness at 3 o'clock, after ingested 4 mussels around 1:30 p.m. like that. So 1.5 hours later, the presentation of symptoms occur. So upon arrival to the emergency department, he vomited once, and there is dysarthria with a bit of slurred speech. Again, similar vital signs appear hypertensive and tachycardic. However, this patient have paroxysmal atrial fibrillation. Second ECG were normal. First ECG is rate control AF around 100 to 110 like this, and there is reduced sensation of a bilateral upper limb. Blood parameters were normal. Sorry, it's not rate control, it's a bit tachycardic. I don't have the ECG with me. So this patient came 1 hour after the patient number 4. So the patient actually treating again as paralytic shellfish poisoning. So this gives a striking clue, because we have a cluster of patients with a different age, similar symptom with different age, who came at the same shift. Yeah. So when this patient came together, so we did early notification made to the district health officer, to at the hospital level, as well as primary team, which is general medical. General medical together, we inform our physician. So a bit about, we stop there, and I shall continue my case presentation afterward. So here is about types of paralysis, the hidden peril of shellfish. A little bit of marine biotoxin. So marine biotoxin, already mentioned by the earlier presenter, is a naturally produced chemicals by certain types of toxic microalgae. So based on the chemical structure, marine biotoxin are divided into hydrophilic and lipophilic types. However, most common can found here in Malaysia is CEPSIGClinToxin, causing paralytic shellfish poisoning. Another common toxin is tetrodotoxin. These two are most commonly found in Malaysia and being reported. But I believe there is more toxins related in our country, but it's all underreported. Okay, so toxic microalgae is consumed by marine organisms, particularly filter feeding species such as the mollusks, the bivalve mollusks, such as oysters, shell mussels, clams. Okay, so these shellfish accumulate biotoxins and transmit it to human and animal through food chain. So mainly when we at risk of exposure to this biotoxin, mainly during consumption, ingestion of contaminated seafood. So on top of that, exposure also can occur if we have a physical contact with the seawater during active bloom or harmful algae bloom, and also inhalation of aerosolized toxins. Okay, so what is harmful algae bloom? Harmful algae bloom is mainly there is a condition at the sea there is proliferation of alga. So this alga dinoflagellates producing biotoxins, and it's actually harmful to human and as well as the environment. So there is a seasonal variation in whole worldwide, mainly in equator area, equator region in Garisan Khatulistiwa. So Malaysia located 7 degrees north, so from the equator line. So that's why it's quite common here in Malaysia, in Philippines. On top of that, there is also outbreak in outside Asia, such as North America and Europe. So this harmful alga bloom, or we call as red tie, has been reported since 1976, and mainly because of Pyridinium bahamims. So this is the alga. So since the first incident, there is actually reoccurrence or recurrence of the harmful alga bloom has been observed in Malaysia. So this is example image I took from the start in 2023. This is the image of the red tie in Sabah. So when there is red tie, or we call it as harmful alga bloom, it means that a certain organism has bloomed and proliferate, causing changes at the sea. You can see that it's a bit brownish or red in color. So these blooms is significant because there is actually proliferation of the alga which producing toxins and that accumulate in the shellfish. So there is changes here, as you can appreciate here. There is brownish color of the sea on the sea. Okay, so where does this toxin came from? Again, this toxin synthesized from the dinoflagellates or alga. So it can be transmitted, actually ingested via food chain. So this harmful alga bloom proliferate a lot during this red tide season, and it can be transferred to the other marine creature by ingestion. So eventually these mussels also, as a filter feeding mollusk, can accumulate these toxins and also be eaten by human beings. So this toxin does not really harmful to the shellfish itself, but it's harmful to us. Okay, why exactly bivalve shellfish? This is all bivalve shellfish. So mollusks accumulate toxins more than the fish because they are filter feeder. So the difference here is that these clams, oyster, or mussel pumps a large amount of volume of water through their bodies and filtering out tiny particles. So inside, the toxin accumulates and concentrates. Even on top of that, there is ineffective detoxification from the mussel itself. In compared to, let's say, fish, once the toxin being ingested, there is normal physiology can be eliminated or excretion. But in these mussels, no such thing. So there is ineffective detoxification. They ingest the microscopic organism, for example, the dinoflagellates alga, and there is no metabolic detoxification as compared to fish. Hence, the toxins can't be eliminated. And nice to know that the toxin may be able to store up to 2 years. So human, all of us also can, the interesting fact is that the toxin is heat stable. So no matter how you cook, the toxin remains in its state, so there is no hydrolyzed bond or anything, it's not even protein. So it can't be denatured, it can't be destroyed. So risk of shellfish poisonings increase also, and whenever you eat raw shellfish, raw meal preparation. Okay, so move on to few shellfish poisoning syndrome. We have 4. Most commonly here is paralytic shellfish poisoning, followed by neurotoxic shellfish poisoning, diarrhea, and amnestic. So azaspiracy was part of diarrhea shellfish poisoning. So the clinical manifestation is almost the same, but there is few striking features, and also the mechanism of action is different. So first is paralytic shellfish poisoning. The toxins is CEPSIGClinToxin. The action mainly it act on fast voltage gated sodium channel. So it inhibits the this channel, voltage gated sodium channel, and subsequently stop or inhibit signal propagation to neurons. So these toxins is produced by dinoflagellates algae, most commonly Alexandrium, tamarins, catanella, and metunium. So these are the source of these toxins. So the symptoms as fast as 30 minutes up to 3 hours, and the symptom can last up to 5 days. So what are the symptoms that is manifested? Numbness from the mouth, the lips, and the throat. So as in our patient, we have they have perioral numbness, ataxia with gait imbalance. They also can have nausea and vomiting, and frank paralysis. So mortality mainly because of respiratory failure. So the mortality rates reach 12%. And then we have neurotoxic shellfish poisoning. So this is brevetoxin. It stimulates sodium channel mainly at the sympathetic nerve. So you can see there is parasympathetic overactivity such as bradycardia, bronchospasm, and even convulsions. So the culprit here is this dinoflagellates called Carina brevis. Okay, the onset is also it's quite fast, within 15 minutes up to 3 hours, and the symptom may last 2 to 3 days. Okay, this is quite common but never been tested the toxin, which is diarrhea shellfish poisoning. So it is derivative of arachidonic acid, which binds to the intestinal epithelial cells, increase permeability, and increase secretion. So the source is from Porocentrum species, based on the name diarrhea shellfish poisoning. So they can have diarrhea, vomiting, abdominal pain, nausea, and it is significant extracellular loss causing hypovolemic shock. Again, the onset is from 30 minutes up to 5 hours, and even can last up to 3 days. Okay, move on to azaspiracid poisoning. It's like the same as diarrhea shellfish poisoning. This one is different. Amnestic shellfish poisoning. It is due to domoic acid, excitatory neuronal degeneration. The features toxin of the similar like glutamate. Glutamate is an excitatory neurotransmitter. So it can cause neuronal degeneration, and patient might have loss of memory because there is degeneration on the process of the hippocampus of amygdala. So symptoms, GI symptoms, cognitive impairment, hemiparesis, convulsion, and this one can cause memory loss. Okay, so the memory loss can persist until several months in severe cases. Okay, now we specifically look into paralytic shellfish poisoning. It was first reported from Sabah in 1976 with few mortalities occurred. Later, we can see cases in Malacca, Kelantan, and Pahang at Peninsula Malaysia. And recently in Port Dickson, here we have 11 cases of outbreak last year. So far, only paralytic shellfish poisoning only been reported, but none of other shellfish poisoning, either because I'm not tested, and it is also underreported. Okay, so this is in details, the dinoflagellates, the causative organism is dinoflagellates, Alexandrium tamarins, Alexandrium catanella, and Alexandrium metunium, which are known food source of the shellfish. So the shellfish involved in this outbreak toxicity, mussel, oysters, cockles, clams, and scallop. So as I mentioned, shellfish accumulate toxin without harming to themselves, but these toxins are very heat stable and not destroyed by cooking. So all incidents involve non-commercial or self-collected shellfish. Okay, so here is the paper from Philippines actually, 3 years back. So this is the magnified image of the paralytic shellfish poisoning organism forming the toxins. In Port Dickson, this is the one. Culprit here is the Alexandrium species. It is so small, up to less than 10 micrometer. Okay, a bit of history of paralytic shellfish poisoning in Malaysia. So we have the first case in the west coast in Sabah. There is a lot of victims, 202 victims with 7 mortality, and it is mainly because of Pyridinium bahamin species. Okay, next we have first case reported in Malacca, first red tide season related to paralytic shellfish poisoning in Malacca in 1991 with 3 victims. And then again in Sabah, there is 20 patients with 1 mortality. And then in 10 years back, again occurred in Kota Kinabalu, 58 victims with 4 deaths. And also reported in Kuantan. This one, paralytic shellfish poisoning. The mussel was collected illegally at the Kuantan seaport. So this is illegal. It's not Malaysian. The victims is not Malaysian, but the patient the patient survived actually with no mortality. Again, occurrence occur after 1 year. There is reported case of paralytic shellfish poisoning at the same area, same location. They're harvesting the mussels with 8 patients. If I'm not mistaken, there were 2 intubated patients, but there is none of them died due to shellfish poisoning. And then in Labuan also has been reported with 2 victims in 2023 because of many and frequent occurrence of paralytic shellfish poisoning outbreak. So there is active surveillance by Department of Fisheries, and there is warning made by them when the paralytic shellfish poisoning or the toxin level exceed the danger threshold. So there is active surveillance, continuous monitoring, and warning to the other shellfish fishermen who be harvesting them. So eventually there is no victims reported till now. Okay, after that, okay, in 2024, again occurrence, the outbreak occur in Port Dickson. So the culprit here is Alexandrium species Prorocentum and Shudonidza. We have 11 victims, but fortunately we have no mortality. So what are the story about these 11 patients? So I have mentioned about these 5 patients. We did notification after 2 patients came similar presentation at the same shift. So we have identified and notification made. And then 2 hours later, this is a husband and wife. Okay, so the husband with comorbidities, an elderly 70 years old male with end-stage renal failure, triaged to level 2 care, resus, presented with sudden onset perioral numbness. Okay, remember we already made notification like 2 hours before and new patient came in. So he came with bilateral upper limb numbness and weakness at 6 o'clock after 4 hours injection of 4 muscles. Upon arrival to the emergency department, GCS is full. Patient actually full but eventually arrested, patient paralyzed. So first patient has tachycardic followed by dysarthria. Eventually he has arrhythmia with multifocal PVC. During that assessment, there is reduced sensation of a bilateral upper limb. System examination are remarkable. Okay, a little bit delayed. Eventually patient become fatigue and respiratory failure and hypoxia. So CPR performed and there is written of spontaneous circulation because it's a witness arrest after 2 cycles of CPR. The patient crashed intubated and ventilated to ICU with regular dialysis subsequently to eliminate the toxins. Okay, this case also was consulted and notification made. Immediately patient was sent to ICU. His wife, who is 69 years old female, presented with similar presentation with comorbids, hypertension and dyslipidemia. Same presentation, bilateral upper limb numbness and perioral numbness after almost 4 hours post injection of 2 muscles. So she has vomited 4 times. Sorry for the typing mistake. She also noted to be hypertensive and tachycardic with reduced sensation of the upper limb. System examination are remarkable, ECG sinus tachycardia. So we notified this patient also. Okay, so after notification, we realized that is there a possibility of us missed any patient. So we have notified at the hospital level, and all the head of department are aware, especially general medical and pediatrics. So meanwhile in the general medical ward, remember our first patient, so he able to be extubated a day after. This is the case of status epilepticus. Following extubation, he actually did ingest 9 muscles. 9 muscles at the same day of presentation. So we revised the diagnosis. The status epilepticus is mainly because of paralytic shellfish poisoning. Okay, another patient who was treated as posterior circulation infarct. Okay, he also admitted that he ingested 6 mussels, so revised the diagnosis again to PSP. And also the third patient who presented with hypertensive emergency with CVA. So this is the father of the fourth patient. He also ingested 4 mussel during the same day of presentation and revised diagnosis. Okay, and then we have a few other patients with similar presentation. This is a bit quite significant because the patient are also intubated and paralyzed, 63 years old. This is night shift with primary aldosteronism, diabetes and hypertension, also with hypothyroidism. So pH retrieval for less responsive, triage to level 1, presented with sudden onset perioral numbness. Prior to that, she has been taking 6 mussels at 7:30, and the symptoms occur in 1.5 hours. She vomited and became less responsive with GCS of 6 during presentation. Pupils were dilated bilaterally, and the patient was intubated and ventilated to respiratory paralysis. So this patient admitted to ICU, and the patient's daughter-in-law who ate this mussel as well had similar symptoms, which is perioral numbness and vomiting and headache. So this patient was admitted to general medical ward. Okay, last patient at that the day after. Last patient after 24 hours, a bit milder symptom after notification has been made, but this patient is actually stable. We admitted for observation. So there is active notification, and also news came to report all these poisoning outbreak in Port Dickson. So following that, suddenly there is a last patient that we have who came on the 3rd April because of the symptoms developed like a day before. So he has resolved symptoms, but mainly came for reassurance. So the patient was discharged from the emergency department. So in summary of this case series, so we can see all patients are adult, and also the distribution here is adult. We have no pediatric patients, half male and female. So we can see the severity of cases according to number 1 is the amount of muscle consumes, and also when the patient has comorbidities. So the highest amount of consumption here, the first patient, 9 muscle, the patient who has status epilepticus and intubated. And then we have the patient with end-stage renal failure, have premature ventricular complex and intubated in ICU, require regular dialysis to eliminate toxins. And also this lady with comorbidities also came with respiratory paralysis. Okay, the onset of the symptoms varies between 2 to 4 hours and also 6 hours. All of them have CNS manifestations, CNS such as perioral numbness, all of them, bilateral upper limb and lower limb numbness. Okay, only one has seizure. This one came with altered mental status. 50% of them have hypertension, tachycardia, and also arrhythmia. Arrhythmia mainly seen here, atrial fibrillation and PVCs. GIT symptoms also present in 4 of 11 patients, and all being admitted except one patient observed in ED, and the other one came with resolved symptoms, so doesn't require admission actually. So the patient, all patients survived. Length of stay according to severity lah. Alright, so from this case we found out that 81% have symptoms within 2 to 4 hours of injection. All of them presented with CNS manifestation. 27 patients require admission. 36 patients have GIT manifestation of nausea, vomiting, and diarrhea. And fortunately, all patients were discharged well with good neurological outcome, although being CPR or being dialyzed. Okay, so this is the news article in Berita Harian. So, Here, the clinical manifestation onset symptoms appear within 30 minutes up to hours. The severity depends on the amount of toxin ingested, and the neurological symptom most common here is ataxia, perioral numbness, and dizziness. Paresthesia may progress from the lips, extending to the face, and then to the extremities. And patient also can have flaccid paralysis, which leads to respiratory failure. Okay, so for those from outside Malaysia, the incident of this outbreak occurred in Port Dickson, Malaysia, in Port Dickson, Negeri Sembilan. This is Malaysian map. Here is Peninsula Malaysia. Negeri Sembilan is situated here. Port Dickson is one of the district in Negeri Sembilan. Is actually a tourism center. Okay, so Seremban is the main city in Negeri Sembilan. The distance from Seremban to Port Dickson is around 30 to 35 kilometer. So the sampling made for mussel harvesting area mainly at two places, which is Kampung Sungai Sekawang and Kampung Teluk Pasir Panjang. It's a bit 4 to 5 kilometers. 3 to 4 kilometers actually from this popular hotel, Lexis Hibiscus Hotel. So the mussel are being harvested here and sampling made by the Department of Fisheries. Alright, so this is the image of the Department of Fisheries and also PKD taking sample from the suspected harvesting area. And then the toxicology report shows there is presence of CEPSIGClinToxin, which is the concentration is more than 800 parts per billion. And the microalga here is Alexandrium, Pleurocentrium, and Pseudonitsa. Alright, so the mussel, the patient number 4, the patient number 4 who cooked the mussel, actually kept them in their house and the same sent to the district health officer for further analysis. And then the mussels actually is high load of biotoxin because it's more than 800 parts per billion. So the result we obtained from Departments of Biosecurity Center in Kuala Lumpur. All the samples were taken on the 3rd of April, and then samples were taken every weekly, and then we found that there is decline of the concentration, but still the harvesting is being banned during this period of time. Okay, general management for these patients, supportive care remains the mainstay of the management. Patient require early intubation for signs of impending respiratory failure. Because we have a patient just now, one of them a little bit delayed in recognizing respiratory failure, and the patient arrested. Some of patient has a lot of comorbidity. So this patient we have to be careful with. Okay, if the patient have seizure, treat as benzodiazepine. GI decon to eliminate to actually mainly to reduce absorption by using activated charcoal. Also can use multi-dose activated charcoal for presented within 2 hours post-injection. ECG mainly to assess for arrhythmia and need to monitor electrolytes to avoid exacerbation of arrhythmia. However, there is no currently antidote available for human. There is research done which is on the rats using autoantibody against toxin against toxin, but it's no data or any research done on human. So in our case, clinical management in ED, we resuscitate the patient require ventilator support for respiratory failure, supportive mainly, there is no antidote, we consult the expert and also notification made. So in hospital level, we alert all department active screening from triage and all clinical level. Following the case number 4 and number 5, so we already inform all the triage officer to triage the patient in at least level 3 with similar symptom despite different variety, despite having various age. Let's say we have young ke old or pediatric who came with numbness, perioral numbness, all become very a bit anxious now at that point of time lah. Okay, to avoid risk of if let's say we miss any potential paralytic shellfish poisoning. On top of that, we did data collection, identify the hospital director, require multidisciplinary involvement, and active screening in patient, because we also missed 3 patients earlier. At district health level, we informed the district health officer and nearby klinik kesihatan are being alerted. Also, notification made to fishery department, and also there is a public safety awareness strategy to ban any harvesting activity around Port Dickson, as well as consumption or ingest this kind of mussel. They have to throw away all the mussel that had been brought by them. Meanwhile, at the state level, CPRC and the health of CPRC mainly for press conference, and also notification made by the JKN. Okay. Alright, because now in the era of social media, so the news spreads very fast. The advantage is that patient came with simple symptom. Also, we have a low number of patients because they're afraid they took let's say clams or oysters or even other shellfish. Also, they actually came to the healthcare facilities to seek treatment, although they are not actually have no symptoms of paralytic shellfish poisoning. So the awareness which is made very well by the social media. So after 4 months, okay, after 4 months, finally the ban has been taken off, and then the harvesting can be done in Negeri Sembilan. So a year later, okay, learning from that case last year, a year later, which is in August 2025, mainly 1 month ago, again, the fishermen actually realized that there is changes nearby Kampung Teluk in Port Dickson and Kampung Sungai Sekawan, the same area of the shellfish poisoning outbreak. So it's not that really red tide as per this image in Sabah, but the changes is like become brownish in color. So what happened was there is notification made to the Department of Fisheries. Actually, following last year incident, there is one monthly screening made by the Department of Fisheries, and then the level is below than 400 parts per billion, so it is safe to harvest mussels. Active screening done 1 month, every monthly until now. Okay, and eventually the fishermen saw that these changes of the sea. So what happened? So a complaint made by the local fishermen regarding an unusual color changes is the possibility of harmful alga bloom. So the Department of Fishery take action by doing sampling. So the initial sampling was collected at 2 points here, which is Kampung Sungai Sekawan and Kampung Pelanduk, here Pusat Nelayan. Okay, so Biosecurity Department in Kuala Lumpur also reported presence of Alexandrium from this first sampling activity. So, and then the result came back as paralytic shellfish poisoning toxins level, toxin levels above 800 parts per billion. And there is official biotoxin report has been issued and press conference has been made, and there is notification throughout in the Negeri Sembilan and also in Malaysia, mainly for ban all the harvesting mussel at the particularly in Port Dickson area. So following this day, the second sampling conducted, and also the level is above 800 parts per billion, and they made this committee meeting. Okay, so the result of the first water sampling was Alexandrium species at these 2 sampling area. So you can see the Alexandrium species is more than 800 parts per billion. On top of that, we have species Pseudonitza and Porocentrum. All these dinoflagellates producing toxins. And muscle sample also confirms the presence of toxin level. So based on that, it's confirmed that it's actually a harmful alga bloom in that area. So that area is clean. It's not really clean. The harmful alga bloom is what we call this considered resolved. Resolved when the biotoxin level below 400 in 2 consecutive sampling in 1 month. Okay, so first changes of sea was made. First changes on the sea noticed by the fishermen, and notification was made in the early August, and then active screening made, And eventually, after 1.5 months, now the shellfish actually safe to be eaten and safe to be harvested and eaten. So fortunately, there is no more outbreak in parotid shellfish poisoning following active screening. So what we have learned in this case, there is diverse clinical manifestation of mussel poisoning with different severity. We have different numbers, different age, varieties of symptoms. Patient came with status epilepticus. We have patient came with cardiac arrest. So we have patient with paralysis. And patient with mild symptoms, just perioral numbness that require observation and can be discharged. So they will have different severity. So timely diagnosis and appropriate management are essential because we have a patient who delayed in recognizing impending respiratory failure and patient arrested. And also most important here is prevention strategy to avoid more outbreak, include public health and education, surveillance by the Department of Fishery and strict regulatory measures to reduce incident of outbreak. Okay, that's it for my presentation. This is my area. I would like to say thank you to Dr. Azahana as well for supervising me for this presentation. So this is my outline of reference. Okay, this one I would like to share. I am one of the committee members for Emergency Medicine Seminar Series here. Prof. Khaldun is my supervisor. We have that time, we have Dr. Sabrina, Dr. Dazlin, Dr. Azahana, and Dr. Taufik. Here is me as one of the committee members.
Wow.
All right, thank you so much.
Thank you very much, Dr. Siti. For that comprehensive, insightful presentation. Your talk has shed light on the clinical features, diagnosis, and management of the shellfish poisoning, an important condition of often overlooked in emergency practice. Thank you very much, Dr. Siti.
Okay, welcome.
Okay, now we'll move on the forum QA session. Just a minute. Okay, now we move on our forum QA section. Sorry, Dr. Yon is not available. So the section will be with Dr. Emilia and Dr. Siti. Okay, I'll go on with the first question for Dr. Emilia. There is a question from the participants. What are the most common marine poisoning you have encountered during working in American Samoa? And what are the challenges you face while handling these cases, for example, like antidote or antivenoms? Dr. Emilia?
Yeah. So as I was saying earlier, the marine poisoning is not that common in American Samoa. The recent one that I had was a very, it was not, not so serious case of cyanide poisoning in terms of how do you call it? It wasn't really they weren't sure, actually. They weren't sure. But because it was noted that cyanide fishing has been, done or being practiced in some areas, even if it's not allowed. So the patient presented with diarrhea and vomiting, but it was not really serious, and we just hydrated the patient. And as we know, there's really no antidote for toxin. So we just gave supportive treatment. And there were also cases of fish poisoning, but I was not the one who attended to the patient. And more often than not, these cases are actually just how do you call it? Minor cases, and by hydration and supportive care, we were able to discharge the patient accordingly. So there were no cases of admissions to the ward and ICU admission, as especially for cyanide. We all know that cyanide is not a joke. I mean, for all the medical students, by now, cyanide is one of the most fatal poison around. And you are aware that, as I've mentioned earlier, this was very rampant when I was in training, because really left and right, I didn't know about this just silver jewelry cleaner until I saw several cases, like they were like self-harm incidents. So as I've mentioned earlier, once that you are able to give the antidote immediately, the effect is really dramatic. As I've said, they will come GCS3, that's it. So intubate, ventilator, etc., etc. Give them the antidote. After a few hours, maybe 1 or 2 hours, they're already wanting to extubate themselves. That's how dramatic it has been with the silver jewelry cleaner. But this was addressed by the government, and they banned cyanide as a component of the silver jewelry cleaner. Yeah, and also, but for the turtle meat poisoning, I haven't encountered that in American Samoa, but in the Philippines there were reported cases, and I know that there were some children who died because maybe they were not brought to the hospital right away, so they were not aware of the seriousness of the cases. So I think the take on this is, with these kinds of incidents or cases, especially for cyanide, this is really not a joke. Just bring the patient to the hospital, because especially bring the patient to the equipped hospital, not just primary hospital. Bring to the equipped hospital and referral hospital, and those who are known to have poison control centers, because you will be able to help your patients more. Yeah.
Okay, thank you for your answer, Dr. Emilia. And there is one more question from Prof. Caldon to you, Dr. Emilia. How about the marine poisoning cases in the Philippines? Many are using TikTok showing the preparations of puffer fish, cooking and eating them, not professional chef like in Japan. How to increase public safety to such cases? Dr. Emilia?
Community involvement, I think, Dr. Cal. We need to strengthen all the more our outreach programs. I mean, our training programs especially in the coastal areas, because sometimes this TikTok are not really helping. TikTok videos are really not helping. It is making things worse, because they think that they're really like Superman, like, without training. That I know for a fact that for you to become a professional um, person to prepare this puffer fish is it takes a lot of training. It's not a simple training, just like 1 or 2 days. I know that they even have a license for this. So I think we need to really give more community education, and encourage them to have help seeking behavior, and prevention is always the key. I think public health education should be increased, and we will tell our dear Dr. Ted about that, Dr. Cal, or you can even tell him also.
Thank you, Dr. Emilia, for your answer.
Yeah.
Okay, we move on to Dr. Siti.
Yes.
There's a few questions from the participant. Does the preparation of the shellfish affect the poisoning? If cooked, the heat, how long enough? Does it reduce the risk of poisoning?
Actually, it is heat stable. The toxin is heat stable. So no matter how long you cook, it won't be destroyed. The only way is you have to throw away all the mussels that you have brought. Or maybe I have this suggestion. Yesterday I met with Dr. Yvonne. she mentioned this technique of actually you don't know what the status of the mussels, or the shellfish. So the not the dead mussels lah, I mean the alive mussels, you can soak in the like plain water in a container, just to eliminate the toxins, you see, to dilute them. But the toxin itself, once you ingest it, you can have manifestations, but in order to destroy itself, no other way. This is the truth answer.
Other way.
I see.
Just throw away.
Okay, thank you, Dr. Siti. I just want to ask, is there any sensitivity the temperature for the mussels? So when you soak with the warm water or like normal temperature water?
Normal water should be okay, because in seawater is not even hot boiling water, right?
Yeah. Okay, thank you. Okay, we move on the second question for you, Dr. Siti. Okay, great sharing on the history of multiple cases presented with the neurological symptom, but not a typical stroke presentation. Are there better approach so that we don't miss out these cases in ED next time?
Oh, okay. So approach mainly for this one is a neurologic emergency lah. Let's say what common is more common. So commonest things are always we think rather than the rare disease, you see. Okay, if let's say you have encountered patient with neurological emergency, let's say maybe seizure, my approach would be by mnemonic of vitamin D. Vitamin is vascular cause. Vascular can be because of what? Hemorrhagic stroke, yeah, epimal formation, B vascular. And then I can be infection, but in this case quite weird because patient has no temperature documented, was completely well before. And then VIT, T is trauma. Trauma can be eliminated, exclude, this is not even traumatic head injury. And then A, autoimmune. Is there possibility of, let's say, autoimmune condition, for example, GBS? Okay, M is metabolic. But before that, the autoimmune, maybe you have either history of autoimmune disease or maybe trigger the autoimmune. For example, any recent URTIs, any recent AGE symptoms, you see. Okay, but none of this present because the onset exactly within how many hours? 2, 3, 4 hours, right? And then VITAM. M is metabolic cause. Metabolic, let's say because of diabetic or thyroid disease, idiopathic, and neoplasm, and the drugs. Drugs can be methanol, ethanol, or maybe vapes, because we have a mixture of fentanyl and ketamine inhalant, okay? And drugs, not to forget the toxins. So in this case, consumption of mussel is the significant history and similar onset with different age variety. So that's my approach upon patient with CNS emergency. Does that answer the question?
Yeah, thank you. And a few more questions. And did the main issue of the health alert about the possible shellfish poisoning before diagnosis of all the victims with PSP? Additionally, the potential for PSP poisoning would have been prevented earlier prior to the outbreak.
Sorry, can you repeat the question again? Sorry.
Did the Marine issue a health alert about the possible shellfish poisoning before diagnosis of all the victims with PSP? Additionally, the potential for PSP poisoning could have been prevented earlier prior to the outbreak.
Okay, so in April 2024, there is no specific complaints made by the fishermen regarding harmful alga bloom based on the observation. We only have symptoms, we have clusters of patients with similar symptoms presented to us. Then only we make a notification to the public health. Public health is kesihatan awam, public health. So they are the one who liaise with the Department of Fisheries to for them to make for them to take action against ban this harvesting of mussel to prevent furthermore outbreak. So since this is the first time of Port Dickson Hospital encounter mussel outbreak poisoning, so we learned from that. So that's why they have made a monthly surveillance program from the Department of Fisheries, and finally this year we have zero outbreak. So they have done active surveillance, active screening, and also public health education. So this have prevented us from getting victims or maybe patients. So it is an effective program, I believe, because based on that last year experience, yeah. So this time around we have no victims, and we are only in alert state, so that we have whenever we have information from the Department of Fishery, whenever they did a release statement and we are going to disseminate the information to others, not only to our healthcare provider, but as well as to the public.
I see. Okay. During a shellfish poisoning outbreak and a surge in a small district hospital, how can the ED with a limited resource prepare and respond effectively?
Okay, good question. So in Port Dickson Hospital, we have maybe daily patient loads from 200 to 150 daily in during weekends and public holiday, but it can be less than 200 in non-busy day. So this outbreak actually occur during weekdays. Okay, during weekdays. So the first few patient that we missed, okay, and then after we recognized first patient, and then notification was made. So and then the information spread along, and then we have search of patient who can be numbness for whatever reason, but the patient not even take consume shellfish, actually they only consume seafood. So we have to like screen those patients actually because the community become anxious, you see. They took seafood also, they scared, and they come to us with vomiting, came with nausea, came with numbness, and even we have patient with hyperventilation. So we have to screen properly which patient is significant patient that need to be notified. So how do you respond is mainly we need a multidisciplinary involvement lah. In this case, we have to involve public health officer as well as klinik kesihatan nearby KK, and if let's say those yang ventilated or intubated case, if let's say we are not able to manage, or we have to transfer patient mainly to tertiary center, let's say HTJ as the month, but notification and also a committee must, number one, notification must be what do you call this alert, yes, alert and surveillance program. And number two is involvement not only from your emergency physician or colleague and multidiscipline, and together higher authorities, you see, let's say the hospital director and also director of public health officer.
Right. Okay. Thank you, Dr. Siti. And there are a few more questions also. We move on with which type of shellfish poisoning may manifest from the three identified type of the dinoflagellates from the sampling by the fisher department. What are the clinical types of the shellfish poisoning that occur?
Which type of shellfish poisoning occur in Port Dickson based on clinical symptoms and signs? Okay, so this one is paralytic shellfish poisoning. Okay, in compared to neurotoxic shellfish poisoning because of brevet toxins, so the mechanism is mainly glutamate and excitatory neurotransmitters stimulate parasympathetic, so they can have bradycardia, bronchospasm, seizure. But in this patient, we don't have bradycardia, we don't have bronchospasm. We have more like we don't have any of those with respiratory symptoms. Convulsion, yes, one, but it's not neurotoxic. Actually, it have mixed feature, but more towards paralytic, because our diagnosis is mainly made by clinical and support only after toxicology analysis. Okay, so it has been proven that the toxin, so it confirms our diagnosis of paralytic shellfish poisoning instead of neurotoxic shellfish poisoning because of brevet toxin. Some more at that point of time, the toxin being tested is only toxin. There is no brevetoxin tested from the fisheries, biosecurity fisheries in Kuala Lumpur. Okay, number two, which type of shellfish poisoning may manifest from key identified types of dinoflagellate from the sampling by the fishery department? Which type of poisoning? Okay, as mentioned, paralytic shellfish poisoning is due to toxin. So the three main dinoflagellates which produce this toxin is Alexandrium, Chlorocentrum. One more, what is? Yes, this lah. What are the clinical type of shellfish poisoning that occur? I think I have answered this.
Yeah.
Why only them now? Okay, why only the diagnosis of PSP from toxin being made or announced by the authorities and not the toxin from other species causing neurotoxin? Okay, because the brevetoxin is not being tested. Okay, note that in study many patients showing CNS neurotoxic feature. Agree. How are they being analyzed for confirmation analytical toxicology? So you can only confirm by testing for neurotoxic is by brevetoxin. If patient with domoic acid, can have amnesic shellfish poisoning, but it's not being tested. And somehow it's not cost effective. You see, number one, commoners being reported or outbreak in Malaysia is mainly because of paralytic shellfish poisoning. So definitely the test is available for toxin. However, underreported case, let's say neurotoxic, azaspiricid, amnesic, all actually not being tested. I think because of the less not that being reported, or maybe it's not cost effective, I believe. Number four, how was the surveillance and public awareness safety action taken in PD? What are the action taken for prevention recurrence? Okay. So the Department of Fishery has made active surveillance by weekly or 2 weekly sampling actually. Okay. Yeah. So they will only relieve the ban after less than 400 parts per billion. So what are the action taken for prevention of recurrent accidents? So I think memang public awareness lah the answer tu.
Okay. So another question that we want the suspect of a patient has a PSP with a history of muscles consumption. How long should I observe in the ED? How do I know that patient can be discharged?
Okay, so the understanding of CNS manifestation following injection is that you can have the onset within as fast as 30 minutes. Okay, but the symptom may last up to 5 days. It depends. If based what we have learned from this case, if the patient has many comorbidities, let's say renal impairment, so you understand that toxin elimination can be impaired. So you can need to be admit this patient with elderly with multiple comorbidities. Number two, the amount or the muscle ingested. If they ingest a lot, we anticipate the symptom may progress even up to paralysis. So this patient definitely need to be admitted. In comparison, patient who are young, just taking maybe a little amount, maybe you can observe in if you have observation room, up to 24 hours.
Nice. And is there any long-term sequelae from the PSP poisoning effect, Dr. Siti?
Long-term sequelae, I believe when there is permanent organ damage. Okay, because this toxin can be eliminated within 2 to 5 days, symptoms may resolve. But if you are delaying organ support, for example, delay intubation, delay ventilatory support, patient may eventually become hypoxic, then there is risk of secondary brain damage as a result of our delayed treatment. In terms of resuscitation, long-term sequelae, let's say in Malaysia, I think there is no reported such case, but mortality, yes, mortality is 12% because of respiratory paralysis. So for long-term sequelae, from my reading, not much. Maybe Prof. Kadun can share because our patient has no neurological sequelae following discharge.
Okay, and one more last question for you, Dr. Siti. Why brevetoxin is not being tested?
Again, this is I think because of cost effective. It's not never been reported before.
Okay. Thank you, Dr. Siti, for your answer.
All right.
Dr. Emilia? Dr. Emilia, are you there?
Yeah, I'm here.
Yeah.
I was just listening to her.
Okay, I have one question for you. What are the marine envenoming encountered in America Samoa or in the Philippines? From the participants.
Marine envenomation. There's quite a lot actually in the Philippines. Primarily, we have our. Remember, I told them about the marine envenomation caused by the vertebrates and invertebrates, such as the lionfish, stonefish, more commonly, and what's this? The snakes, sea snakes, yeah, and of course the fire corals, and definitely the box jellyfish, which is the most dangerous, or it's the most fatal jellyfish, the box jellyfish envenomation. We have cases, yes, and they usually occur during the warm months as expected. That's why we have been really going around our remote areas to teach them about prevention, as well as how to respond to this box jellyfish envenomation. So for American Samoa, thankfully, honestly, we don't really have that much cases. So as I've mentioned earlier, there are really no land snakes. So wise, we don't really have that much of a problem. But of course, like when, as I've said, it's surrounded with bodies of water. Likely there are snakes, sea snakes, but sea snakes are not really. They don't, as we all know by now, snakes, if left alone, will never attack us. The attack part, unless you hurt them, as we have been teaching our medical students. As long as you do them harm, then that's when the problem begins. So with this in mind, we are able to prevent issues with snakes. And the other thing that I want to mention is the fact that for the Philippines, we are still really trying to cover a big part of our country. So, Dr. Gita, I think
Yes.
yeah,
Yes.
you were saying,
No,
something.
carry on.
Yeah. So as I was saying, there's still a big part of our country which we haven't been able to reach in terms of the proper training, but hopefully, with this first Toxinology Congress, we will be able to reach further, and reach those who are really in need of this training and this education to prevent marine envenomations.
Thank you, Dr. Emilia. Thank you. Okay, there is a response from Prof. Khaldun. A shellfish poisoning is caused by dinoflagellate that produce various toxins, leading to different types of poisoning, including a paralytic shellfish poisoning, PSP, from Alexandrium species, and Gymnodium catenatum, neurotoxin shellfish poisoning from Carinea brevis, and direct shellfish poisoning from Dinophysis species. Other types include amnestic shellfish poisoning from Pseudo-Nitschia species and Azaspera shellfish poisoning from Azadinum spinosum. I think this is for Dr. Siti.
Thank you, Dr. Caldon.
As mentioned by Dr. Izni, the lab could only test for the toxin and not other toxin related to the cases. Therefore, that is why we are seeing a mixed picture of clinical signs suggesting toxin and brevitoxin, which also related to the sampling of the species of dinoflagellates sampled in the areas affected. but not from the lab. It shows issues of analytical toxicology in the country. Thank you, Prof. Khaldun, for your answer.
Yeah. If I may add, Dr. Gita,
Yes.
so remember for ciguatera and toxism, we don't have antidotes. So maybe this would be a challenge for the younger generation to do research, and maybe they can come up with antidotes for these toxins, right? So
Yes. Thank
help
you.
us do the research, the younger ones.
Yeah, those are in the participant who are interested
Yeah.
to do this topic of research. Furthermore, can contact Prof. Khaldun.
Yeah, Dr. Caldon will be the
It
boss.
will be free for help. Okay, thank you very much. Anybody want to ask any question to Dr. Siti and Dr. Emilia? All right. Thank you, Dr. Emilia. Thank you very much, Dr. Siti, for your active participants and
Thank you.
yes.
Thank you for giving us the opportunity
Yeah.
to.
Terima kasih.
Thank
Sama-sama.
you.
Thank you. Thank you. All right.
Okay.
Okay, now, before we wrap up today's sections, let's move on the something fun and interactive that is our Kahoot quiz here. The quiz is a great way to create what we learned today on marine envenomations and poisoning, while testing our knowledge in a light-hearted way. There is a prize awaiting our top scorer, so give it your best shot. Okay, the winner, please take a snapshot of the proof of the winning and later please contact Dr. Chim. I will post in the chat box her email. La 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 la. Is the winner at the moment? Wow, la la la.
Give to someone.
The slow
All right. At the end, our quiz, and the winner is Chihuahua. Is the winner. Okay, Chihuahua, don't forget, snap the photo of the quiz winner. Well, as we come to the end of today's seminar, I would like to thank all our esteemed speakers, Dr. Yon Teo Chang Poon, Dr. Emilia Santa Maria, Dr. Siti Nur Izni, for sharing their expertise and clinical experience with us. A special thanks as well to the organizing committee, for organizers, sponsors, and all the participants for your active engagement throughout the session. We hope you enjoyed today's program and found it both educationally and practical for your clinical work. Just a quick note to all participants, we are unable to share the presentation slides, but the video recording of today's session will be made available during our next CME session. Please remember to complete the QR scan attendance and claim the MMA CVT points. Well, thank you again, and we will look forward to seeing you at the next section of our third week of the 7th Emergency Medicine Seminar Series 2025 on the topic of land envenomation and poisoning. They held on October 23rd, 2025. Have a great day.
Yeah, thank you. Terima
Thank you.
kasih.
Thank you, Dr. Emilia. Thank you, Dr. Emilia.